Hello everyone. I thought I would go live. I had a great dialogue just now in the Practical OT Facebook group, which I highly recommend. It's put on by Chris Narwald. I don't know if I'm saying your name right. You'll have to correct me, Chris. But Chris shared a post of the Intentional Relationship, which is a seminal occupational therapy textbook on therapeutic relationship, which was edited and facilitated by Renee Taylor, who was the spouse of our esteemed founder, Gary Kilhoffner, who developed the model of human occupation. So one of the more commonly utilized models of occupational therapy practice, both in the United States and leveraged internationally, particularly in Western and European cultural contexts. I've been very impressed with how practically useful the intentional relationship text is. So as I get around to it, I'll post a link in the description. But Chris wanted me to speak to in relationship to therapeutic relationship and therapeutic use of self on the psychosocial domain of OT practice and how often that is somewhat like sidestepped or avoided, or the sense of like occupational therapists being sort of like naughty in the US. And interestingly enough, I actually got some context on this week from Gail Fisher in terms of context from some of the foundations of when occupational therapy services were being initially like defined in relation to Medicare, and how at that time in the late 60s and 70s, there was just as much, I guess, I don't know if this has ever changed, but there's just always been a lot of resistance in the United States for mental health parity and investing equitably in mental health and physical health infrastructure, which OTs have always been at the intersection of, because we started in the memorial treatment movement and the arts and crafts movement. Many of our most prominent founders started out in psychiatry and social work and nursing. That, a lot of our infrastructure in the United States started in the mental health and insane asylum situations and workshops, things that were actually quite outside of the medical model or significantly predated the medical model in the United States. And what I was pointing Chris to consider as he was asking my perspective on this, on, ways to like feel confident incorporating the psychosocial. So I thought I would share some of my tips. So one of the things I reference is our context with Adolf Meyer as one of our core founders. He joined with Eleanor Klogschlegel as one of the founding teams of the American Occupational Therapy Association back in 1917, and he's a psychiatrist who coined the term biopsychosocial framework as it relates to psychiatry, because he utilized occupational intervention in his initial psychiatry programming with arts and crafts workshops and things like that. And you can see a true through line actually from that era of OT practice and how Chapter 10 of CMS's guidelines, something I've noted over the past decade is I think a lot of occupational therapists have not gotten an opportunity to deeply read our CMS guidelines and regulatory infrastructure. Many OTPs in many cases may not even be aware of the existence of the practice framework, which is why I think we have to start talking about it more online. If I'm not mistaken, I think that started in 2001, and we still have something like 30 to 40% of practicing OTPs in the United States graduated before we had these frameworks fully developed and fleshed out. And this is in part because we weren't able to fully have autonomy in developing our curriculum until the late 80s and early 90s in relation to the American Medical Association. So that's a big part of our foundational skill sets not being fully understood in the medical model, is in relation to not being able to decide our own curriculum until the 1990s. So there's so many helpful tools that have been developed now that like OTs have been developing their own curriculum for the better part of 40 years now. But I wanted to bring up Adolf Meiter and founding the biopsychosocial element. So since our founding, mental and physical and contextual health have always been integrated through our definition of occupation. And that persists to this day with our most contemporary theorists in defining what occupation is. It's inseparable from the psychosocial and contextual domains. So in our current definitions of occupational therapy in the OTPF4, it's not occupation if it's only looking at the biomechanical aspects. It has to incorporate meaningful and purposeful activity, which is technically a metaphysical concept and also takes into account volition, client motivation, a lot of those MOHO things. So in the way that I relate to practice, even in traditional Medicare settings, you can't separate occupation from those aspects of a person. And so the way that you can feel confident in incorporating a psychosocial lens on your OT practice, even in traditional biomechanical settings in the United States, is kind of through this policy playbook. So the first thing to know is that in order to bill CPT codes, we're required by the OTPF and AOTA to set up an occupational profile. And an occupational profile is I think of it like the Pokemon card of whatever the client is that we're working on. What are their skills, strengths, all their different diagnostic profiles, where are they at in relationship to their lifespan development, what were their key significant roles and shifts. And there are different ways that we can get snapshots on this that are applicable, especially in acute care. The occupational profile plays a huge role, but know that that's legally required to create prior to billing CPT codes as part of the formulating the occupational therapy intervention. So just right there, in order to do that ethically, it doesn't actually make you a better clinician to exclude your client's psychosocial challenges. Many of our clients that are impacted by physical disability, whether it's breaking a hip, getting into a car accident, or having a stroke, there's a significant amount of grief, occupational deprivation, often depression, life role incoherence that is taking into account that I think we need to be confident about claiming too, because often when our clients are going through these significant transitions and occupational disruptions, they're not in a position to access traditional mental health services in the United States. And even if they were to access them, they're not often customized for the intersectional impact of physical disability and mental health and role stagnation. So that's one of the ways. But I also want to cite chapter 15? I'm going to link it below, or it's chapter 10 of CMS guidelines where occupational therapy services are formally diagnosed. You can find many ways where Medicare describes that it doesn't discriminate services on the basis of diagnosis. And we have had almost like 15 years now of this premise of mental health parity at the federal level, that services that are provided and necessary for physical dysfunction are meant to be equitably applied for those that have a mental health dysfunction. So if you read, I think it's chapter 15 of CMS guidelines, formal definitions of occupational therapy services, one of the top cited definitions of what constitutes skilled occupational therapy services is sewing for reality orientation for a schizophrenic patient. It directly calls out that occupational therapy is a service for psychiatric diagnoses. The way that you think of this is not occupational therapists providing traditional psychotherapy type services. It is making occupational therapy services accessible to those whose occupational barriers relate to their psychosocial prognosis. Psychosocial domain is relevant to occupational performance across the lifespan. In peds, they see this significantly. So many more of peds referrals relate to developmental trauma, ADHD, CPTSD symptoms, and whether or not they're the primary diagnosis that you're putting on your treatment form, they most certainly are impacting your progress and performance. I highly recommend Carlin Neek's acceptance and commitment therapy training for OTPs if you're wanting to look at developing an intentional evidence-based skill set around psychosocial supports. Motivational interviewing is another good one. it's our job as OTs to be integrative, holistic thinkers, regardless of what setting we're practicing in. We still have to engage with our clients as occupational beings. It's very clearly outlined in the OTPF4. But yeah, highly recommend reading through our CMS formal care guidelines, leveraging parity, and then utilizing, Renee Taylor's therapeutic use of self. There is such phenomenal guidance. If you truly follow that, you will be astounded at what's possible building those skill sets. I've always been kind of incredibly bored by biomechanical based OT. I'm such an arts and crafts OT at heart, and I can tell you that part of my value in the teams that I work on is providing adaptive services, particularly for those that are impacted by neurodivergence, such as ADHD and bipolar disorder. Even when, because like everybody breaks a hip, everybody gets a shoulder replacement, and that's sort of the cool skill set, especially through the occupational profile. No matter what setting we're at, we just pivot the kaleidoscope of our lens to meet and be client-centered where they're at. Particularly grief around the loss and transformation of occupational roles. The last tip that I was giving to Chris too is that in occupational science, we have these amazing constructs and phenomena that our other colleagues don't really have, correlations to in the same way, or that we have our distinct lens on. Things like occupational deprivation, which is being disconnected from meaningful and purposeful activity and having a loss of autonomy in practice. Or another example is occupational apartheid, being excluded. This often happens in SNFs, for example. I found that many of my clients with different levels of dementia, for example, might get excluded from a specific area of the dining room or not allowed to go on community outings, which is experienced psychosocially. And, even if these are something that are like a small side that you're like noticing and acknowledging, I use the geriatric depression scale quite a bit, and it's pre-built into my home health setting. And that's something that you can use for the Medicare population if you're wanting to speak directly to the psychosocial domain, even if that's just like a side piece to your lens and is not one that is like something that you feel comfortable leading the role. Know that, just noticing these things and developing familiarity with trauma-informed care and validating another's emotions can also be a valuable point for you to be a vehicle for appropriate referrals to higher need services. That's part of our role as advocate, is connecting our clients to appropriate community-based resources and advocating for how the mental health professional services can actually be adapted, maybe for somebody with aphasia or somebody with a hemiplegic stroke. That's where we pivot our lens and adapt to fit these systems. It's a hugely beneficial part of our skill set. I'll also include below some links to the testimony that was effective in Washington State Senate Bill 5228 that was able to unanimously get passed community-based Medicaid reimbursement services for behavioral health OT that has a lot of language about how you can use a psychosocial lens in traditional practices. I truly believe that our foundations in the moral treatment movement, the arts and crafts movement, and mental health infrastructure in the United States before it was aggressively defunded is part of our secret sauce and our unique contributions on the rehab triad. Compared to speech therapy, physical therapy, we have the most training in the Diagnostic Statistical Manual and a wide diversity of diagnoses that also interact with the physical healthcare system. And so I think really being confident about that perspective and taking time to do the professional development to feel confident with that, which again, if you're looking for a start, check out Carlin Neek's Activate Vitality Primer on learning how to use the ACT, which is not a gate-kept modality. It's something that any profession and any person can use. But yeah, definitely very nerdy about this. I'm very passionate about making sure that even physical health occupational therapy services are equitably accessible to clients that are getting physical health procedures done within the Western medical system. There's no reason why, it certainly doesn't make you a better provider to like somehow put blinders on around the neurodivergence and mental health diagnosis of our clients. So it's a big part of your power, your value as an OTP team member, and including your role as an occupational therapy assistant. There's something so manageable about engaging in meaningful, purposeful, agency-driven, client-driven occupations that help bring people back. Like creative arts and play are, you know, highly regarded to be almost the opposite of trauma. So I have been learning about that through the Window Between Worlds, trauma-informed art certification, and embodied social justice certification. Those are things that have really helped me up-level that. And just like Chris highlighted, you know, the therapeutic relationship, that is just a gold standard. If you haven't got a chance to pick that up, please check it out. Thank you, guys.